Hello, I'm one of the plastic surgeons at Loma Linda University, and I'm really excited to talk to you about breast reconstruction today. This talk is not meant to replace professional medical opinion regarding individual patients. I have no financial disclosures. 1 in 8 women, that is how many women in US develop invasive breast cancer in their lifetime. I hope you never have to find yourself having to deal with breast cancer or taking care of a loved one dealing with breast cancer, but it doesn't hurt to know your options. My job here is to help try and empower women so they can make informed choices about breast reconstruction. Let's get started. So, whenever I see patients for a consultation for breast reconstruction, they're already quite overwhelmed with because of the diagnosis and everything else associated with it. So, I really try my best to simplify reconstruction to them. Basically, when it comes to breast reconstruction, there are basically 4 questions. Why get reconstruction? Who can get reconstruction? When to get reconstruction? And what type of reconstruction to get? Let's start with the why question. Why get breast reconstruction? So, breast reconstruction has implications beyond just the physical aspect of having a breast. It has implications from psychological and emotional standpoint. Several studies show that there's improved quality of life with breast reconstruction. There's also improved body image, self-confidence, and most importantly, studies show that most women who had breast reconstruction were satisfied and they would recommend to others in similar situation. Next question is when to get breast reconstruction. So there are 2 options when it comes to timing for breast reconstruction. First option is to start the breast reconstructive process immediately at the time of tumor resection. And the second option is to get delayed breast reconstruction, which means that you complete your tumor removal, sometimes even your chemo and radiation if needed, and then consider options for breast reconstruction. This is before and after photos of a patient who chose to get delayed breast reconstruction a couple of years after her tumor resection, and you can see she was able to achieve a decent result. Next question is who should get breast reconstruction? So in my opinion, or typically the women that I see, there's almost no woman who was not a candidate of some type of breast reconstruction. But there are several factors that come into play when we decide the best type of reconstruction for the particular patient. These factors include type of mastectomy, whether it was skin sparing mastectomy, nipple sparing, or a total mastectomy, history of radiation, smoking, diabetes, body habitus. If a patient is interested in using their own body tissue for breast reconstruction, then what type of tissue is available to them, their physical activity, job requirement, and that sort of a thing. Lastly, and most importantly, what type of breast reconstruction should you get? So broadly speaking, there are 4 options when it comes to reconstruction. And we'll go over all these options. So the first choice is to just forego breast reconstruction and just use a prosthetic in your bra just to make up for the deficient side. This is for women who are not interested in breast reconstruction. They just want to feel symmetric while they are in their clothes, and this is certainly a reasonable option. However, most women who I see in my office, they are young, healthy, and they should at least, in my opinion, consider and learn about the options for breast reconstruction. So the next choice is breast tissue rearrangement. Basically, this is an option for women who are candidates for partial mastectomy or removal of part of the breast, and there is enough breast tissue remaining that we can rearrange it utilizing a lot of the breast lift techniques and give them a decent mound of the breast. typically what happens is that patients go to sleep for their tumor removal, and at the same time, under the same anesthesia, after the tumor removal, breast surgeon comes in and they reconstruct the cancer site breast, or basically by rearranging the breast tissue in a way to try and give it a little bit of a lift and make sure that there's blood supply to the remaining breast tissue that is nice and robust. And a lot of times we try to address the opposite side at the same time and do reduction to match the cancer side, so that when the patient wakes up, they're for the most part, they're done with their reconstruction. So again, this is only the option, or you're only a candidate for it if you are a candidate for a partial mastectomy or breast conservation surgery, where the tumor is only removed from part of the breast. Whether you're a candidate for a partial mastectomy is something that you and your breast surgeon will talk about usually prior to seeing me in my clinic for reconstruction. Next option is implant-based breast reconstruction. And this is a very common option that women tend to choose because because of its simplicity. This can be done in 1 stage or 2 stages. Again, it depends on several factors, whether you're a candidate for a 1-stage reconstruction or a 2-stage reconstruction. So basically in a 1-stage reconstruction, patients, they go to sleep or under general anesthesia for their tumor removal. Once their tumor is removed, then we use an implant to fill in the breast envelope that is left by removal of the tumor and the breast tissue. This can be filled in with a saline implant or a silicone implant. Patients who undergo skin-sparing mastectomy, at least, and usually a nipple-sparing mastectomy, are candidates for a 1-stage breast reconstruction. In this type of reconstruction, we are unable to upsize the breast by too many sizes, just because that's going to put too much tension on the skin envelope, and that can possibly decrease the blood supply to the skin, which we never want to have. So the next type of reconstruction is a 2-stage implant-based breast reconstruction. In this type of reconstruction, we place the tissue expander, which is basically a balloon that has a port in it, so that we can fill in that port later. And this balloon is placed under your skin, and the skin is closed over it. This balloon can be placed either under the muscle or over the muscle. Once the skin is closed over it, we let the skin rest for a couple of weeks. Then I start the reconstruction process in my clinic. Each time patients see me in my clinic, I fill in a little bit in their breast envelope so as to make it a little bit bigger each time. Once we have achieved the size that we're happy with, then we let the breast tissue rest for a few weeks to a few months, depending upon whether they're going to get radiation or not. And then patients undergo another anesthesia to remove the tissue expander and replace it with a permanent implant. Typically, the second surgery is an outpatient surgery. So this is a patient who underwent delayed breast reconstruction. This is prior to her first stage. This is with the surgical markings, where we measure the most appropriate size of the tissue expander for the patient. This is her photograph after the tissue expander has been placed under the skin envelope. And this is following the swapping process where we remove the tissue expander, replace it with a permanent implant. Lastly, let's talk about autologous breast reconstruction. So autologous breast reconstruction is when we use your own body tissue to build you a breast. There are several sites of the body where we can uh, borrow the tissue from. Most commonly, the deep flap. So other options are S-gap, I-gap, tug, and latissimus flap, and we will talk about these options in a little bit more detail. So first and foremost, deep flap. So deep flap is a flap of tissue that comes from the belly or the tummy under or below your belly button. We take a flap of skin along with the fat underlying it, as well as a blood vessel. The blood vessel tends to lie under your six-pack muscles, so we have to dig in and make sure we grab it as a block and then completely detach it from the tummy and attach it to the chest. This is attached to a blood vessel in the chest under a microscope. So microsurgical expertise are required. This is a longer operation than the implant-based breast reconstruction. So this is a picture of a patient who had a deep flap. As you can see, the scar goes from hip to hip. And usually this scar ends up a little bit higher um, than what you would see in a patient who had just a tummy tuck operation. Other less common options for autologous breast reconstruction include TELG flap and S-gap or I-gap flap. So TUG flap is a flap that comes from your inner thigh. We're able to reconstruct a small to medium-sized breast with this type of breast reconstruction. S-gap and I-gap flaps are flaps that come from your buttock area. Again, this is another type of autologous breast reconstruction where microsurgical expertise are required because the tissue is completely detached from the body, one side, and then attached where we want the fullness in the breast under a microscope. So not everybody is a candidate for this. It depends on whether you have tissue that can be spared, but these are some of the options for autologous breast reconstruction. Lastly, latissimus dorsi myocutaneous flap. So this is a very robust, great option. A lot of times we use it as a sort of a savior options in women who have history of radiation, their skin is too tight, or they've lost their reconstruction for an infection or exposure of the implant or other reasons. In this option, we use the muscle in the back along with the skin and fat overlying it. And we use a chunk of muscle and then we swing it around in front without detaching it completely. It's kind of just swung in front. And a lot of times we have to place an implant under it just because it doesn't create that much of a bulk to create a reasonable sized breast. So this is sort of a hybrid option in between the autologous and implant-based reconstruction, since it utilizes your own body tissue as well as an implant. So lastly, there are some adjunct procedures that we utilize sometimes, most commonly being fat grafting. This is a great option. Usually we use this option to fill in some contour irregularities, or we can sometimes even slightly increase the size of the breast using fat grafting. Basically, fat is liposuction from other parts of your body, and then we inject it and sort of lay it in layers wherever it needs to go. A lot of times women with, especially with implant-based breast reconstruction, they end up with a little bit of hollowing up in their upper pole of the breast, and we can use this fat to just sort of camouflage those upper pole and give it a little more natural appearance of the breast. So this is definitely a great option. And then there are nipple and areolar reconstruction procedures. Usually we perform nipple and areolar reconstruction once we're completely done with the breast reconstruction. There's several ways to reconstruct nipple and areola. Areola is the colored part around the nipple. The nipple, the projecting part of the nipple usually is reconstructed by rearranging the tissue on the breast skin so that you create a little bit of a tiny mound for the nipple. And areola can be reconstructed in several ways as well. One option is to take a sort of a shaving of skin from other parts of the body that are slightly darker, so, and then place it around the nipples to create darker areola. Another great option is nipple areolar tattooing, where we just tattoo the areola, the colored part. You can also tattoo the nipple part, and there are options for 3D tattooing as well that creates an illusion of having a nipple without having the projecting part of the nipple, which is a great option. So this brings us to the end of the talk. I really hope this talk answered some questions for you. These are definitely some exciting times as breast reconstruction has really evolved over the last couple of decades, especially in the last 10 years. We're now able to reconstruct a breast that is fairly natural, and it's almost as good as a natural breast. There will certainly be some differences. It will not be exactly like the breast that you were born with, because this breast will not have any feeling in it. But usually the reconstructed breast can also be very aesthetically pleasing. Breast reconstruction, in my opinion, is definitely a very important step for so many women to move beyond their diagnosis and reclaim their lives. If you have any other questions, then we would love to help you, and we would be happy to see you in our office. I wish you well.